Раз, два, три. Hello guys, today we start talking about burns, and this section is about thermal burns. Thermal burns are skin injuries caused by excessive heat, typically from contact with hot surfaces, hot liquids, steam, or flame. Most burns are minor and can be treated as outpatients or at local hospitals. I think that you have the burns too, and uh, it will be good if you know what you need to do if you have this type of injuries. Approximately 6.5% of all burn patients receive treatment in specialized burn centers. The decision to transfer and treat at burn centers is based on the extent of body surface area burned, the depth of the burns, and individual patient characteristics such as age, other injuries, or other medical problems. Burns occurring in the home account for 25% of all serious burns. Etiology. Thermal burns are the most common type of burn injuries, making up about 86% of burn patients requiring burn center admission. Burns often result from hot liquids, steam, flame, or flash, and electrical injury. If you watch lecture about electrical injury, yeah, you can find it up. You know about this type of trauma. Risk factors for thermal burns include young age, children of come into contact with hot liquids, male gender. Males are also at high risk for burn injuries, chiefly due to occupation-related injuries. Additionally, flame burns are also common during the summer as many people use gasoline products for recreation or farming. Alcohol consumption is a common risk factor in areas who suffer uh, burn injuries. Lack of smoke detectors in the home. When immersion scald burns are present, one should always suspect child abuse by the parent or caretaker. Epidemiology. Excuse me. 450,000 patients receive treatment for burns annually, and about 30,000 require admission to burn centers. About 86% of burns are thermal burns, 43% from fire flame, 34% from scalds, 9% from hot objects. 4 electrical burns, 3 chemical burns, and 7 are other types of burns. Annually, approximately 3,400 patients die from burns or related complications such as smoke inhalation, carbon monoxide, or cyanide poisoning, organ failure, or infection. Roughly 72% of these deaths occur from residential fires. Burns represent the fourth leading cause of trauma deaths and the second leading cause of accidental deaths in children aged 1 to 4. The good news is that the overall survival rate for all types of burns is about 97%, and deaths from burns have declined by about 75% from the 1960s. Pathophysiology. Of course, you need to remember about the layers of skin. How you see in this picture, there is just 3 layers. Yes, epidermis, derma, and subcutaneous tissue. Of course, for the doctors, it is not normal knowing just these layers. You need know more layers. That you need remember that epidermis delayed for more layers. Yes, 6 layers. Dermis delayed for 8 layers, and subcutaneous tissue don't delays in any layers, but there we have some another interesting moment. But for patient, you can answering like this. The skin is the largest organ of the body, making up about 60% of a person's weight. The main skin functions are protection, infection, temperature change, physical forces, chemicals, body temperature regulation, preventing fluid loss, and cosmetic or identity. Yeah, there picture better for you to remember about the dermis. Yeah, what we have inside the dermis, and how you see there we can have hair root, hair follicle, sebaceous glands, yeah, oil glands, um, uh, deep. Of course, don't forget about erector pili muscle. Yeah, in the skin we have muscle. What else? Eccrine sweat gland. um, that's all what we have inside the uh, dermis. And of course you need to remember about Pacinian corpuscle. Uh, Deeper we have adipose tissue, sensory nerve, fiber, yeah, and you see that it coming to the muscles, yeah? And some nerves go to the epidermis, upper layers of epidermis. Uh, and this is the reason why it's too bad when we have the problem with the dermis. Yeah? Two primary layers comprise the skin, the thinner outer layer called the epidermis and the deeper, thicker layer called the dermis. There are various other structures within the skin like hair follicles, sebaceous glands, sweat glands, capillaries, and nerve endings. Talon burns cause both local injuries and, if severe, 20% of body surface area, a systematic response. First degree, how you see, we have the problem with epidermis. Second degree with derma, and third degree we have the problem with deeper layers, yeah? Subcutaneous fat, muscles, and, for example, the bones. Local injuries. The local injuries can be roughly separated in three zones of injury, analogous to a circular target pattern. The innermost injury is the zone of coagulation or necrosis, representing the area of irreversible cell death. Zone of coagulation or necrosis. Yeah, you see this one. It will be in the center of the target. Yeah? The next one, surrounding the zone of ischemia or stasis, representing an area of decreased circulation and an area at increased risk of progression to necrosis due to hyperperfusion or infection. Yeah, it is this zone of stasis. Um, The outermost area is the zone of hyperemia, representing an area of reversible vasodilatation and an area that usually returns to normal. Yes, it is this. Right. No, better to look at there. Yeah? In clinical practice, burns are dynamic injuries that may progress over hours to days, making it difficult to accurately determine the various zone during the early course of the injury. And there you see how much active things we have inside the wound, what have the burn. Large burns, more than 20% of body surface area, also causes a systemic response from the release of inflammatory and vasoactive mediators. Fluid loss locally at the burn site, fluid shifts systematically, plus decreased cardiac output and increased vascular resistance, can all lead to marked hypovolemia and hyperperfusion called burn shock. This condition can be managed with aggressive fluid resuscitation. History and physical. Most burns are small and classified as minor burns, with the primary symptom being pain. These burns will need only local burn wound care and pain control. If the patient has extensive and deep burns, then they may be classified as severe burns and could be approached like other trauma patients. Examination. If the patient doesn't have severe burns, then the history and physical examination can proceed as usual. Key parts of the history to include area, the type of burn, it is thermal, electrical, chemical, or radiation, the possibility of associated inhalation injury, for example, trapped in an enclosed space, and the possibility of other injuries, explosion, or jumped to escape fire. During the physical exam, special attention should be placed on the airway and breathing, looking for oral burns, facial burns, soot in the nose or mouth, coughing, wheezing, or labored breathing. And please don't forget about this one because it is most important when you look the patient. If he have the burns of the face, yeah, burns of the oral, nose, and others, it always can lead to the big problem with breathing. Also look for signs of injury other than the burns. Finally, the burns are the focus of the skin exam. TBSA. The key features to assess are the extent of the burns expressed as a percent of total body surface area. Total body surface area, TBSA, burned in the percent, and the depth of the burns expressed as superficial or first degree, partial thickness or second degree, or full thickness or third degree. There you can see the interesting marking, uh, the rule of the nines, but we will talk about this one after. If the burn injury only involves the epidermis, it is classified as a superficial or first degree burn and does not cause any significant impairment of normal skin function. Yeah, there you see the first degree, the superficial degree, the third um, no, it is the second, but it is deep uh, when the hypothermia will be deeper than the papillary layer. And the third degree, how you see, we have the problem with hypodermis. If the injury extends into the dermis, it classifies as partial thickness or second degree burns. Partial thickness burns may disrupt skin functions such as protection from infection, thermoregulation, prevention of fluid loss, and sensation. Partial thickness. Yeah? Superficial partial thickness and deep partial thickness. Um, There we have the blisters and whips. With increasing depth, increased risk of infection. With increasing depth, increased risk of scarring. If the injury extends through both layers, this is a full thickness. All third degree burn and normal skin function are lost. And this is one is a full thickness degree. Yeah, of course we have the fourth degree when we have the problem much deeper and we see the bone. If we talk about the full thickness, there are dry, insensate to light touch and pin prick. Small areas will heal with substantial scare or contracture. Large areas require skin grafting and high risk of infection. Superficial or first degree burns are warm, painful, red, soft, usually do not blister, and will blanch when touched. A typical example is a sunburn. The partial thickness of second degree burns can vary, but are very painful. Red, blistered, moist, soft, and will blanch when touched. Examples include burns from hot surfaces, hot liquids, or flames. Full thickness of third degree burns have little or no pain, can be white, brown, or cherry, and feel firm and leathery when touched and will not blanch. Examples include burns from flames, hot oils, or superheated steam. Evaluation. The American Burn Association criteria can help differentiate burns as minor, moderate, or severe based on the extent of the skin injury, the depth of the burns, age of the patient, associated medical conditions, associated injuries such as smoke inhalation or other trauma, and burns involving particular areas of the body such as the hands, feet, face, ears, nose, or genitalia. Burn sites quantification is essential when making a decision about treatment and admission, and the rule of nines is often used. For adults, 9% of the total body surface area to the head and neck, 9% to each upper extremity, 18% to 90 to the anterior and posterior trunk, 18 to each lower extremity, and 1 to the perineum. Not hard to remember, but it's not really better to use this classification. The patient palm, and it is better, present about 1% of the total body surface area. Yeah, for example, 1%, 1%, 1%. Also, burn injury can subdivide into partial and full thickness injury. Yeah, and there you see the child's the rules of nines, yeah, but in the child, and you see that it not like in the same for adults. Mere bone injury, how they delayed, more than 25% of total body surface area in adults or 20% in children. Full thickness burn involving more than 10% of TBSA. There is burn to the face, perineum, or extremities. There is significant cosmetic impairment. These injuries are best managed in a burn center. Moderate burn. Partial thickness burn between 15 to 20% TBSA in adults, 10 to 15 in children, or a full thickness burn involving 2 to 10% TBSA. Minimal treat or to face and perineum. The risk of cosmetic impairment isn't severe. These patients need admission but do not always require a referral to a burn center. Minor burn injury. Burns that involves less than 15% of TBSA in adults and less than 10% in children. No treat of functional or cosmetic loss. Face and perineum not involved. These burns receive outpatient management. Burns treatment begins at the site of injury. EMS should assess for inhalation injury by looking for thinned nasal hairs, burns on the nasal and mouth area, respiratory distress, and sooty sputum. Patients in respiratory distress should be intubated at the site. The patient should have an IV started and fluids as ESP in adults. In children, accessing small veins in a dark home can be difficult and transport is more recommended. Local cooling can be applied to relieve pain. For example, ice or some pina colada, with ice of course. The first step is to immediately stop the burning process by removing burning and hot items from the skin contact. Small areas of burn can be cooled with liquids like tap water or saline solution. If the patient has larger burns, be cautious of extensive cooling as this could lead to hypothermia. Superficial burns need little more than over-the-counter pain medicine, topical analgesics, or topical aloe vera. The best type of bandage, how I say. Partial thickness and full thickness burns are treated with cleansing, topical antibiotic ointments, or occlusive dressing, pain medication, and tetanus boosters if needed. Patients with severe burn will require fluid resuscitation, oxygen, cardiac monitoring, nasogastric tube, Foley catheter, IV pain medication, a tetanus booster, and transfer to a burn center. If patients are transferred to a burn center, simply cleaning and covering the burns without topical creams or ointments is all that is usually needed. It is best to contact the burn center for instructions. Inhalation injury must be ruled out in the ED. Inhalation injury can lead to upper airway edema within 12 to 24 hours, and the recommendation is for intubation if there is any doubt. Fiber optic bronchoscopy is possible as it does provide an accurate way to determine inhalation injury. Following control of the airway, one should perform a vertical incision of the eschar on the chest to prevent limitation of chest expansion. Sometimes additional lateral incision may be required depending on the degree of eschar formation. Yeah, there you see a mnemonic flash, clinical findings of an inhalation birth, facial skin, lips, airway, sputum, hair. Yeah, if you see there the suit, yeah, for example, it is important to remember about this rule for a fiber optic bronchoscopy. Escherotomy, what is this? All circumferential fall thickness burn injuries need an escherotomy to prevent compartment syndrome. Yeah, we're talking about the scarring, we're talking about the, excuse me, I forgot in English and in Russian. Uh, Structure. Yeah. If we have the circumferential full thickness burns, we need to do the incisions. Yeah, to don't give for the burns for the skin when it will repair to pushing the organs what is inside our body. Yeah, and it is very important because we will have the compartment syndrome. We don't talk about the compartment syndrome in these years of education, but it is very hard. If you want to look the something about compartment syndrome, you can look the lections. Carbon monoxide and cyanide. Levels of carbon monoxide and cyanide need to be measured, and patients provide with oxygen. One should suspect cyanide toxicity in the presence of several metabolic acidosis, normal arterial oxygen, and low carboxy hemoglobin. All burns larger than 20% TBSA need fluid resuscitation based on the Parkland formula. Crystalloids are preferable to colloids. One should be careful not to overhydrate and cause ARDS. Science, there is a significant amount of protein loss during a burn. Some centers do infuse 5% albumin. A Foley should be inserted for the strict assessment of fluid balance. Blisters. Debate continues over the best way to treat blisters. Large blisters, dense blisters, and blister frozen joints require debridement, while small blisters and blisters involving the palms or soles are left intact. More often in my practice, when I do the removed of the tattoo, I use laser, and after laser we have the blisters. And better when we don't take away the blisters. Better when we do the puncture of the blister with the needle and take away the liquid, yeah, and we don't take away the skin, no, epidermis. It is better for patients because the treatment will be easier. One method of treating partial thickness burns is to cover them with topical antibiotic ointments like bacitracin or triple antibiotic ointment, and then apply a simple absorbent dressing. The ointment can be spread on the dressing like peanut butter on bread, then placed on the burn. Dressings are changed once or twice a day and may take 1 to 2 weeks to help. Silver sulfadiazine has historically been a commonly used topical antibiotic cream, but is falling out of favor with growing evidence it can delay healing. The other method of burn wound management is to apply a specialist occlusive burn dressing to the burn and leave this in place for about 1 week. Yeah, there you see the burn, there you see the using of special gloves, yeah, with air inside, and there you see how it's look like in the 7th day. I think it's very good and very nice. After stabilization of the patient, surgical debridement and grafting are necessary. Yeah, we can do many types of skin grafting. We will talk about this one in the topic of plastic surgery. Now I don't want to talk about this one, but you can see these beautiful pictures, how it looks like. Nutritional support is critical because the base energy expenditure is high. Early enteral nutrition is the recommendation to prevent bacterial translocation from the gut. The patient's caloric requirements can be estimated by using the Curry formula: 25 kilocalorie per kilograms plus 40 kilocalorie per percent of TBSA. Not hard, I think. Please remember this formula. Skin discoloration is a common problem after burn and a source of severe distress. Epidermal grafts are an option, but this is also time-consuming and expensive. Because burns are dynamic injuries, they are difficult to assess on the initial exam accurately. Patients with burns should be re-examined in several days to resist both the extent and depth of the burns. Prognosis. The prognosis following a burn depends on many factors. While first-degree burns have a good prognosis, both second and third degree burns can have high morbidity and mortality. Extremes of age, other comorbidities, facility, experience, and presence of inhalation injury play a significant role in the outcomes. Thank you for your attention, and please be careful in the street. Bye bye, see you on the practice or in the exam.